Very good morning to all of you. And at the outset, let me thank the Kidney Warriors for inviting me, especially Ms. Masundra, for giving me a chance to interact with you all. So, the topic I'll be speaking on today is bedwetting in children, what the caregivers must know. The very reason of selecting this topic is the basically two profiles of patient which recently I shared. So there was one patient, a girl child, 6 years old, who was brought by a mother saying that she wets the bed every like almost 6 days in a week, and they stay in a joint family, and because of which the child is not able to sleep with her cousins because of the embarrassing moments that she has to share once he wets the bed. So I just want some kind of treatment to be given to my child because of the embarrassment. And basically we evaluated the kid, everything was fine, no kidney issues at all. Like the basic evaluation was all perfect. So we just asked her to go in for conservative management, hold on for a couple of months and see whether the child improves or not. I was not too willing enough to start medications for this child because the basic evaluation was all good. And within a span of say around about 1 to 2 months, the mother came back saying that the frequency of bedwetting has almost gone down with to 50% of what it was initially, just with the conservative management without any drugs or alarms or anything. And by the end of another 10 months from the, you can say the from the start of the this thing when she had consulted me, the child had already gone off from the bedwetting issues. Okay, the child has totally been relieved of it. So here was one patient who wanted therapy, and we did not want to offer her drugs and alarms, but only with the help of basic conservative therapy, the child improved. On the other hand, there was another patient who was around 8 years old, a boy child, referred to me for management of urinary tract infection. So while taking the history, found out the child is also bedwetting. Again, similar 6 days in a week that the child used to wet. But on asking the parents for this thing, why haven't you consulted a doctor? So what they told me was, we thought it's okay till 10 years of age. I said, who told you it's okay till 10 years of age? Because bedwetting has a problem. We say only if, like we say, if the child continues to pass urine during the sleep after the age of 5 years. So I told the 5 years is my cutoff, not 10. So no, the father also used to pass the urine in the bed till 10 years. So we thought 10 years is pretty normal. So we did not consult the doctor for it. And on evaluation, this child was actually found to have chronic constipation, reflux, and because of the reflux, both the kidneys have got scarred. His basic creatinine, what he presented to was 2.5. After treatment of UTI, it had come down to 2, but it is pretty high for a child. So had he gone to the doctor long back, maybe 5 years from now, maybe we have prevented the kidney damage. So the big question that arises here is when to treat or not to treat, because majority of the time we know bedwetting improves with age. And the second question is, if you have to treat, what kind of therapy you should offer such children, whether you should offer just a conservative management of urotherapy versus the alarm therapy or drugs. So to tell you more about it, we'll go on to the presentation. So first and foremost, you should know the basic terminologies, like what is wetting. Like normally a lot of patients say we have incontinence, that is uncontrollable leakage of urine at an inappropriate time and place in a child aged 5 years or older. Now this kind of incontinence can be either continuous, where you're continuously dribbling, or it may be intermittent. Continuous incontinence is usually seen in children who have some kind of congenital malformation, or the bladder has got damage and there is continuous leakage of urine. Whereas intermittent incontinence can be of two types, either it was in the daytime or it is at the night time, or especially when the child is sleeping, which is also called as enuresis. Now, enuresis can be of two types, primary or secondary. Primary means the child has never attained bladder control till date. And secondary means the child was continent and for at least 6 months. And now the child has started bedwetting again. So this is secondary enuresis. Now, why we need to differentiate the two is because both have a different cause profile. And unless you know the cause, how will you be able to treat it? And then enuresis can also be divided as monosymptomatic or non-monosymptomatic. Monosymptomatic is the major chunk of patients, almost accounting to 80%, where they have no other problem other than bedwetting. And these are the children who actually improve with age. But if you have associated problems in the daytime as well, like an urgency, you want to pass urine more frequently, you can't hold urine, by the time you're going to the toilet, some leakage occurs, you have to strain while passing urine, or you are unable to initiate urination at the right time. So all these things tell you that this child also has some kind of lower urinary tract symptoms, because of which the problems may arise during the daytime as well. Some kids are in the this habit of holding the urination, and they form different postures just to increase the muscle tone of their genital organs so that they can hold the urine. So in case that is also a scenario, these children are the one who actually require therapy and will not improve with age unless you have treated them well. Now, few facts about nocturnal enuresis. Now, the prevalence of nocturnal enuresis is around 15 to 20% in 5 years old. And as you grow older, every year, 15% of the children will actually improve with age, as you can see in this graph. So, at 5 years, it's 15 to 20%. At 10 years, it is 5%. And at 15 years, it is just 1 to 2%. And this is the major reason why majority people feel like as the child grows, things are going to improve. So we need to differentiate which child will improve and which will not, so that we can act at the right time. And it is more common in boys than the girls. And nearly half the parents do not seek help, mainly believing that child will eventually grow out of problems. It's almost nearly 50% of the patients. And some because they feel things are going to improve with age, and some because of the cultural taboo, because they don't want to go out telling that, okay, my child has bedwetting, because it is linked with some kind of weakness of the genitourinary tract. And then they have the thought process like, if the genitourinary tract is on the weaker side, maybe this child, if it's a girl, will have problems bearing the children as well. So because of that, they may not seek help. Now, we need to know what are the causes of bedwetting, because unless you know the cause of bedwetting, you are not going to treat it well. And now, what I want to focus here is bedwetting. It should be actually taken as like something like a patient presents to a doctor saying that there is fever. So ideally, you can take paracetamol for fever, but unless you know what is the reason of fever, how will you actually treat the patient well? So same goes with bedwetting. First and foremost, find out what is the cause of bedwetting, and once you find the cause of bedwetting, treat it accordingly, because so every patient may have a different you can say treatment profile, and we have to basically trim it according to the patient's need. So various causes for bedwetting is, one is maturational delay. I mean, these are very common in children who have some kind of developmental delay during the early age group, like they attained all their milestones slightly late. So because of that, their chances of attaining, you can say, continence during the day and night also slightly gets delayed. Normally, the continence at night should be achieved by 4 years of age, but even if you do not achieve by 5 years, then only we label you as a child with bedwetting. So in case there is some kind of maturational delay in different milestones, so you can just say, okay, if all the milestones the child was achieving maybe 1 year later, so even this milestone he'll be achieving 1 year later. So you can just hold on, and maybe this kid will actually improve with age. Second is genetics. So genetics is in case one of the parents has history of bedwetting during his childhood, then there's a 44% chance that the child will also be having history of bedwetting. And if both the parents had history of bedwetting during the childhood, the chances are almost 77% as compared to 15% if none of your parents had bedwetting in the past. So it's a genetic predisposition. So these are the children also who improve with age. In a small study that we did in our institute, we found out that 15% of the kids with bedwetting presenting to our institute had history of family history of bedwetting, out of which 73% was first degree relatives, and of them 50% were fathers. So other causes can be a small bladder capacity. Now, small bladder capacity for the age can be inherent, means congenitally you have a small bladder capacity. So this child in the daytime will present with increased frequency of urination, and during the nighttime will have bedwetting. So these children again may not improve unless you intervene here. Or it may be a small bladder capacity which has recently come up. Initially the child bladder capacity is perfectly fine, but because of maybe a chronic constipation like phase, so because of the motions will compress the bladder from behind, so because of which the bladder capacity may temporarily become smaller, and because of which the child may have bedwetting. So here treatment will be treatment of the constipation. Secondly, the next cause is nocturnal polyuria. Normally what happens is, if you divide the total urine output for the 24 hours, okay, so 2/3 of that urine output should be passed during the daytime and 1/3 during the night time. So that's the body's response. Body produces a hormone called as ADH during the early morning, which decreases your urine output. But in case you have problems with your ADH secretion, definitely your nighttime urine volume will be more, and it will be more than what your bladder capacity is. Hence, you will have increased chances of bedwetting. So here, drugs like desmopressin may help you. Then sleep factors. If the child has like adenoids, as seen in this X-ray, so because of it, during the sleep, the child will be restless, will be snoring, will be having mouth breathing. So this also increases your chance of bedwetting. Here, if you treat this sleep factors, almost 30% of the kids will outgrow this disease of nocturnal aneurysm just by treating the sleep issues. And normally what we think is, or what majority of the patients think is, that 82% of the parents were thinking that these children are deep sleepers and lazy. That's why they do bedwetting during when they are sleeping. But actually what happens is, one of the report sleep study which we had done, and we found out that almost you can say majority of your sleep that is was in the light this thing in the light mode, means almost 72%, and deep sleep was only 22%, as compared to patients thinking that majority they are deep sleepers. So basically they are light sleepers, but they have a poor arousability. So in these kids, actually your alarms may help you increase your arousability. Next is constipation. Constipation, I have already discussed with you that if there's a major chunk of stool sitting behind your bladder, so it will compress the bladder and the bladder capacity will become small. So you'll continue to have bedwetting. And if this motions of the bladder actually compresses the bladder outlet, then you have symptoms like hesitancy. You'll unable to pass urine. You'll have an urge, but you'll unable to pass. So if chronic constipation is there, that also should be managed well. Otherwise, it will not only cause bedwetting, but also will interfere with your therapy like desmopressin if you are using for this patient. Then comes ADHD. So children with psychological issues like attention deficit hyperactive disorder, autism spectrum disorder. So these also have a high chance of developing nocturnal aneurysms because of the common shared pathogenesis with the disease entity. So in case those things are there, you need to get in touch with your doctor and treat that as well. Now coming to the secondary nocturnal aneurysms, that means the child was perfectly well for more than 6 months, no bedwetting, and suddenly he starts wetting again. So one of the major reason in current scenario is constipation, and secondly it is stress. So stress can be in the form of death in the family, it can be a parental divorce, new baby in the family, examination failure, sexual abuse, bullying by other children. So any stressors can lead to bedwetting. So you need to tackle the stress as well. So this is a like when you go to a doctor for evaluation of a this thing bedwetting. So normally what it does is makes you make a bladder diary. So bladder diary helps you like what all records do you put in the bladder diary is the timing, and along with the timing what was the liquid intake, what was the kind of stools did you pass, and according to the timing what was your urine output, means how many times did you void and what was the ml of urine that you voided, and how much was the urine output during the night time. So this actually helps you in determining what was the cause of bedwetting, and you can basically tailor made your therapy. Okay, depending on what this child need, accordingly we can treat. And this not only helps in picking up the disorder, but at the same time helps you in prognosticating and also telling you whether you're improving with time or with therapy or not. So that in case you're not improving with the current therapy, you have to switch over to something else. Then the basic pearls of management. One, you should have, like this is what I'm talking is the general urotherapy or the conservative management. So timed voiding means you should not hold urine more than 3 to 4 hours. Void immediately on rising up in the morning and before going to sleep. Adequate hydration. Your fluids should be distributed as 40% in the morning, 40 in the afternoon, 20% in the evening. Avoid bladder irritants like carbonated, caffeinated drinks, tea, coffee, especially during the evening times. Then you should treat the constipation it is in case it is there. Proper positioning of the toilet seat so that child is comfortable while avoiding urine as well as while passing stools. And encourage the child to take out time to the toilet to empty completely. Means the child should be sitting there for passing stools for at least 10 to 15 minutes rather than just sitting for 2 minutes and coming back. Otherwise the stools will be left over in the rectum and this will compress your bladder. Encourage physical activity. Discourage sitting in front of TVs and computer for a prolonged period of time. Tend to be more aggressive if bedwetting is actually bothering the child or the family. And star charts can help in motivational therapy, because the more motivated you are as a family, as a kid, the more chances you will actually come out of it. Then you have alarm therapy. The different types of alarms are available in the market. Some are like some people use the bed side alarms. Some use mats, which get the moment they get wet, they start ringing. But the best that is there is the use of alarms like this, where you have an electrode which is stuck to your this thing tied, which is stuck to your undergarment, and this is connected to a wire. The wire gets connected to your alarm, and this alarm can be put next to your bedside, next to your ears. So we have different forms of alarms in the market. One can be in the form of one which rings. Second one, for the adolescent population who doesn't want it to ring, they have a vibratory alarms as well. So you can use either of them. So this works on the basic principle of conditioning of the child, and it is 60 to 70% effective. But the basic problem here is it is very labor intensive, as can be seen in this cartoon. Sometimes in the initial phase, the alarm will keep on ringing, but the child will continue to sleep, and the whole family gets frustrated that we are awake, but this child is not awake, because they have problem with poor arousability. So remember, if you need to use alarms, it has a good outcome, everything is good, but it takes time. And at the same time, you have to have a motivated child, a motivated family, and even a motivated doctor who keeps pushing you off. Okay, keep using it, and with time you'll improve. Otherwise, you can say almost 70% of the patient will actually come back to you in their first visit and say it is not working. So basically, desmopressin helps in decreasing the nighttime urine output, and it works best when you have a normal bladder capacity rather than a small bladder capacity. So it's available as in the melt formulation. The tablet formulation has always also the spray, but spray has actually been given up nowadays. We use more of melts or the tablets. Then we have drugs like imipramine, which is less used nowadays. And so generally remember, so any child who has history of bedwetting, you must actually rule out constipation and encoparesis, recurrent urinary infections, neuropsychiatric conditions like ADHD, learning disabilities, disorders of sleep, abnormal urine analysis, underlying diabetes mellitus or diabetes insipidus, any deranged renal functions, any problem in the spine as seen in this picture, like there is a scar in the spine or the buttock line is irregular, telling you that this child may be actually having a problem with the spine, because of which the bedwetting may be there. Then worm infestation should be treated. Any child who's not growing well, the height and the weight is not good, again you should think that there may be an underlying kidney problem, and you should always screen for hypertension. So basically a green signal should be given that yes, you are going to improve with age only if you have a normal physical examination, you have a normal BP, normal urine analysis, normal ultrasound, and a normal renal function. Then you can wait. But if you have any abnormality, you should take help and get treated. So the take-home message is, for primary monosymptomatic enuresis, means who have simple bedwetting mostly will improve with age. Between the age of 5 and 7 years, just motivational therapy, conservative measures help. And if it does not, then you can have active intervention like alarms and desmopressin, drugs like desmopressin. Alarms work on long-term basis, but they have good outcomes. Desmopressin helps on short-term basis. Short-term in the sense that if you want sudden improvement, then desmopressin is the best drug that you have. And remember that bedwetting can have serious impact on child's self-esteem, emotional well-being, daytime functioning, including the school and social performance. In youngsters aged between 8 to 18 years, bedwetting was seen as the third most traumatic event after divorce and parental fighting. So successful treatment of bedwetting improves memory, the quality of life, and also reduces the psychological problems. Because of which we keep on having this awareness programs on celebrate World Bedwetting Day in the month of May every year. So remember, friends, we have n number of, you can say, the therapies available for bedwetting. If you go onto net, there are n number of therapies available, from astrological to massage therapy to, you can say, the different food or the home remedies to drugs in homeopathic, ayurvedic, allopathic, alarms. So n number of things are available. But remember, if your child has any kind of problems associated with bedwetting, do not forget to take help. So a child more than 5 years doing bedwetting during sleep, definitely take help, get your child evaluated, and then depending on what suits you, you can take your therapy. So in case anyone wants to come down, you can come down to a bedwetting clinic in Gangaram, which we have established since last 5 years. And with this, I like to end my talk, and maybe we convert all the the wet nights to dry nights in future. Thank you.